and pay our respects across different lands. And I'd like to welcome Anya Buss from UNODC, who will be talking on the international standards for the treatment of drug use disorder, and subsequently Crystal MacDonald and Winifred Assar-Doku will be talking on a project, prisons-based project that they've done jointly with Anya. And without ado, I'll pass this on to Anya.
Thank you so much, Michael, and thank you so much everybody here at ENDAC who's joining us, and everybody who's joining us online and hopefully can hear us well. As said, I'm Anya. I work with UNODC, and really a pleasure to be here. So also, like Michael did, I would also quickly like to acknowledge the traditional owners and custodians of this land, which we are meeting, and elders past, present, and emerging. And you heard saying that I work for UNODC, which is the United Nations Office on Drugs and Crime. We are a medium-sized, let's say, office that has been created to support United Nations member states all around the world in addressing common challenges around drugs, but also around issues such as crime, corruption, human trafficking, terrorism, and we do that through providing technical assistance to member states. So our kind of executive director, Ms. Ghada Wallis, she then reports directly to Antonio Guterres, the Secretary General of the United Nations, and that just to illustrate that we are part of the Secretariat with our headquarters, so being in Austria and Vienna, and we have like offices reaching around 150 countries in the world. So today I'll just speak very briefly about some data around drug use and drug treatment, give you the rationale and tell you how the international standards for treatment of drug use disorders were developed, and give you a hint of what's in there. We'll speak about the dissemination of the standards, and then leading over to the next presentation on this health kind of justice linkages as it affects people using drugs and with drug use disorders. So UNODC produces every year the World Drug Report, which summarizes kind of global data that are shared with us mainly by member states around drug use and related topics. So the latest estimate, which is based on data from 2020, stated that there are around 284 million people who have used an internationally controlled substance or a drug at least once in the year 2020. And that would be roughly 5.6% of the global population between 15 to 64 years. And of those, close to 37 million people would benefit from access to treatment of drug use disorders. And there are an estimated 11.2 million people injecting drugs in 2020 all over the world. And whenever you see a little star in my presentation, that means in reality that I can make an acknowledgement also of the work of ENDAC, because also ENDAC kind of is involved in providing UNODC these national data, so for the global reports, but also makes obviously a lot of the kind of global estimates, including around injecting drug use that were just recently published again. So cannabis use remains the most widely used substance globally, followed by opioids, and then the different stimulant classes. That's what you can see on the picture there. So and then just to say, as we are talking drug treatment, the different regions have very different main treatment needs. So the dark blue on this slide would be amphetamine type stimulants. That's where kind of the main treatment need in Australia, for example, has been identified. The lighter blue would be kind of that there's main treatment demand for more opioid use disorder treatment. The yellow would be the cocaine substances, and the darker green, hopefully you can see that, would be cannabis. So different patterns kind of for which people are mainly seeking treatment in different parts of the world. The global coverage of drug use disorders is still very, very limited. So this is based on member state responses to the annual report questionnaire that UNODC collects regularly. And so there it said that only 16% of countries said that they have full coverage of psychosocial treatment, and 15% of countries only indicated that they have fully adequate coverage of pharmacological treatment. So with this coverage being limited, access to treatment for people with drug use disorders also remains still very limited, or actually this gap has been growing over the years since I work at UNODC, and the current estimate is that only 1 in 8 people with drug dependence would have access to any form of drug treatment. And the situation then is even worse, kind of for women, for adolescents, for people in prisons, for people in humanitarian settings, and other vulnerable groups. So with that epidemiological situation a little bit in mind, let's look at kind of also the rationale how we developed the international standards for treatment of drug use disorders. So first and foremost, I mean, there is an obligation for member states that are part of the International Drug Control Conventions to provide treatment of drug use disorders. So every party to the international conventions has in principle signed up to take all practical measures for prevention, for early identification, treatment, education, aftercare, rehabilitation, and social reintegration. So in reality, this has already kind of framed out an entire continuum of care. And also kind of prevention and treatment of drug use disorders have been identified and included in the Sustainable Development Agenda. So this provision kind of member states said for us kind of as the world to develop further, we need to strengthen prevention and treatment. So also from there comes an obligation. But de facto, the quality of treatment of drug use disorders is often very low, right? So accessibility was low, but also quality is often low. So even well-intended interventions, if not following scientific evidence, might be either ineffective or in some cases even harmful. And that's even worse if we are hearing, and we are still hearing, about kind of severe human rights abuses even committed in the name of treatment of drug use disorders. And with all of that in mind, in 2009, the member states of the United Nations, in a high-level session of the Commission on Narcotic Drugs, in kind of the political declaration that was passed, also requested the development of health standards for demand reduction. Demand reduction meaning mainly prevention and treatment of drug use disorders. In the same year, UNODC and WHO also launched a joint program on treatment of drug use disorders. And then, as these things are, we got to work, right? And there were a lot of expert consultations, draft being made, and so on. In 2016, which was a very critical year for international drug policy, we then had a draft for field testing of the international standards for the treatment of drug use disorders ready, available, and it was shared and launched at the Commission on Narcotic Drugs in March 2016. Where immediately kind of a resolution has been passed by the member states or by the Commission on the dissemination of the standards of treatment of drug use disorders and for the kind of the use by member states of them. And UNODC and WHO have been requested to kind of further disseminate the standards. So they had immediately a lot of backup. In the same year, and that's why I said it was really an important year for international drug policy, the General Assembly also came together in April in New York and addressed kind of the world drug problem. And the General Assembly only meets more or less once a decade on this topic of drugs. So therefore, it was very timely that the standards were already ready, and they were, well, ready as a draft for field testing. And they were acknowledged in the outcome document of this meeting of the UNGAS 2016, as it's often called. With this political backup, let's say, for the standards and the draft ready, the field testing then started. That was mainly led by the World Health Organization. And there were 9 field testing sites, and one of them, I just looked that up, was really also here in Australia, actually even in New South Wales. And the field testing mainly looked at aspects of comprehensiveness of the standards document, appropriateness, utility, and feasibility. And kind of the results overall were quite positive across the different sites. When you look at utility, appropriateness, comprehensiveness, maybe feasibility a little bit less, and that we will come back to, kind of where there maybe additional support then was needed. A lot of the comments that we received were addressed. And then in 2020, the current version of the international standards for the treatment of drug use disorders was launched with the aim really to support UN member states in their own efforts to develop and expand drug use disorder treatment services and systems. So it's a comprehensive document. I just picked out kind of bits and pieces from it. One would be the key principles that have been outlined there kind of with much more detail, and I'll just go through very quickly. So it says how treatment needs to be available, accessible, attractive, and appropriate. That it needs to follow ethical standards, and informed consent kind of is a key point in that. There needs to be coordination between the health system, the justice system, and social services. Treatment needs to be based on scientific evidence, and then needs to be responses for kind of special treatment and care needs of individuals and of certain groups of populations. It's kind of asking for good clinical governance, for having integrated approaches to treatment and continuing monitoring and evaluation. There's an entire chapter also in it on treatment system organization, and again I just picked out this one kind of system organization pyramid, which is following kind of the mental health pyramid that many of you maybe have also seen, and therefore promoting this public health principle that kind of first, the most effective, least invasive, and lowest cost intervention should be implemented, right? So, and that obviously is complicated to find that one, but the other basic message really here is that there should be an emphasis on outpatient services, and services should be as much as possible offered in an outpatient setting for cost reasons, but also to be less invasive kind of to the lives of people in need of care. What nevertheless we see very often is that especially emerging drug treatment systems put a lot, if not all their resources in long stay residential services that of course also have a role in a continuum of care, but this pyramid was kind of designed to help shape treatment systems. Then the treatment, the kind of core chapter really is about treatment settings, modalities, and interventions. So in the treatment settings that are described, again, I mean, continuum of care is the idea in the standards. So they start kind of with community-based outreach or low threshold services, speak about services within non-specialized health services. So for example, primary health care, emergency care settings, then go into specialized outpatient services, short-term inpatient treatment services, and then kind of the long-term residential treatment services, and always thinking the pyramid model. And the modalities and interventions that are described there with much more detail include screening and brief intervention, evidence-based psychosocial interventions like motivational interviewing, cognitive behavioral therapy, family therapy, and so on, pharmacological interventions, so that would include agonist treatment for opioid use disorders, and symptomatic treatment for other substance use disorders, well, for other drug use disorders. Overdose identification and management, the treatment of comorbid conditions, and recovery management. And again, with this notion, of course, that not one size fits all. Populations with special treatment and care needs also kind of have a dedicated chapter. The standards especially speak about women, children, and people in contact with the criminal justice system. For that, so to say, we have already developed, especially the last one, people in contact with criminal justice system, but in reality also the others. We have started to develop, let's say, spin-off documents that go into much more detail into those areas, and that we will also have in the presentation after me. So I'll just leave you this picture for a second that kind of summarizes in a bit ideal world, or this a continuum of care, or the variety of services in a community in this vision of the international standards for treatment of drug use disorders. So when you look around, you see maybe the outpatient center in the middle, and then there is somebody who kind of goes to wash their clothes in a drop-in center. There is an outreach worker who's sitting with people injecting drugs. Somebody goes for voluntary HIV testing. There is a hospital where people maybe get some inpatient services and additional care. There is a women's group meeting. There is a recovery cafe. Somebody is receiving attention for an overdose. So all of this kind of, and the idea that, you know, there should be ideally no wrong door, right? So it's standard setting. So are the standards now perfect and everything in there is exactly, you know, well, maybe not, right? Maybe when you read them, you will say, you know, this chapter or that chapter I would have done slightly different, and this is missing or that is missing. So I think, yeah, I mean, sure, it needs to be a living document, but I think what's important is how widely recognized they have been, since they have been since the field testing version was there in 2016, and then since 2020 we have the revised version. So there is really like a common a reference point, and you see that, for example, in upcoming resolutions that the Commission on Narcotic Drugs passes, this kind of acts already like as a common reference point, and this I will talk about now, for us as we are doing technical assistance with countries all around the world, it has proven very useful to have it as a common reference point and say, you know, this is treatment, there might be other things that you're doing, but let's come back kind of to an international standard. This slide we have seen before, right? So the feasibility was a little bit the lowest, or had a bit the lowest rating when we did the field testing, and therefore to make the implementation or the use of the standards more feasible, additional tools have been developed. So there will be an entire, or is emerging an entire implementation package. I'll just say a few words about the quality assurance tools that we have developed, including with the support of international experts. And I remember that Michael has been sitting with us in some of these meetings, right? And so in quality assurance, really the idea is to support member states in their own efforts, right, to assess their treatment services or systems in line maybe, or in the light of the international standards, and to support them in these cycles of continuous review and improvement, and then for agencies like us to provide additional technical assistance for that as needed. And again, there has been a political backup also for doing that. 2021, the Commission on Narcotic Drugs passed Resolution 64.3 that encouraged member states to develop quality assurance mechanisms, and in the broader text of the of the resolution then asked UNODC kind of to continue providing support. So by now we have a number of quality assurance tools for treatment services and systems that are there. They really need to be understood as living documents, even more so than the standards, for technical assistance, and kind of have a flexible use, be adapted to country level. So I'll kind of speak about, they're similar like in the treatment standards have this chapter on systems, and then the bigger chapter on treatment services, and similar the quality assurance tools also focus on treatment services and look at things such as core management, how is the service managed, right? Core care, which is the interventions that are being implemented, core patients' rights, and then depending on what the service it is, there might be opt-in standards around intervention settings or the target groups. What has been most widely used are the so-called key quality standards for service appraisal, which are, so to say, a condensed or a mostly needed, demanded version maybe of this services toolkit. So when we started using the services toolkit all around the world, mostly these were kind of areas that the countries wanted to concentrate on first. So here you see similar management, patient-centered care, timely access to interventions, and promotion of patient health, safety, and human rights. The systems kind of toolkit is a bit more like, as you would imagine, so it looks more at planning, financing, and so on of treatment systems. And this is just to give you a glance what it looks like when these tools are implemented. So the table is a bit kind of a scoring, right? Red didn't pass, green did pass for a number of treatment services in a country. And kind of this, what you see in the middle would be a way of a distorted or a changed real-life pyramid of a treatment system, right? So where in reality there was much more investment in short-term inpatient treatment in this example than in our ideal model on outpatient treatment. So I'll just give you one example how this is going to support countries. These are the different countries where at this moment or recently we had projects around quality assurance and the implementation of the treatment standards. So in Nigeria was really a pioneer in this. Already in 2019, there was kind of a workshop to build the capacity of national experts around how to do quality assurance, how to work with service providers, and so on. And Nigeria developed its own kind of set of quality assurance standards, and those were then piloted in Kano State in Nigeria. And the immediate findings from the initial visits kind of found, for example, that most of the treatment was not provided in specialized services, but a lot kind of, or people were a lot kind of in homeless shelters or maybe in mental health centers. There was kind of lack of trained professionals to give out medication. There were issues around infrastructure, and they also identified some very challenging situations, like people chained to the walls, and those were things that immediately were addressed. Whereas then some of the more, let's say, strategic or challenges were around lack of guidelines, lack of standard operating procedures, and so on, that were then kind of jointly addressed in the following. And I mean, Nigeria, as I said, really has been a pioneer, so there has been a lot of work in training professionals, in developing national guidelines and national standards. There are a number of model treatment centers, and work is continuing in Nigeria and with Nigeria more than anything. So quality assurance, our experience so far has been rather positive. I mean, we thought that the tools are adaptable to national circumstances, and that they have proven useful kind of to initiate kind of these discussions and processes around where are we now with our treatment services and systems, and what are the things that we as country maybe would like to change and have the resources, and where do we start. So I mean, both services and the systems toolkits have been started to be used. And there will be, so to say, additional dissemination packages developed, including with our colleagues from WHO. So I'm coming to, I mean, that was really about the treatment standards. And just to remind us, so there was one group kind of, I've taken out the slide, but there was one group kind of on people using drugs or with drug use disorders in contact with the criminal justice system. There is a chapter in the standards, but together with WHO, we have also developed kind of another guidance document around treatment and care for people with drug use disorders in contact with the criminal justice system. And this initial publication then has a focus mainly on alternatives to conviction or punishment. And by the way, if you scan these QR codes, they lead you to the documents. So that the team in Vienna has done beautifully. As we are talking about the alternatives to conviction or punishment, and this wording is very long, but I think it's important to be precise, for people with drug use disorders in contact with the criminal justice system. So just to highlight very quickly that there is a supportive international framework that includes the drug control conventions, but also other internationally agreed rules, like the Tokyo rules, which are the United Nations standard minimum rules for non-custodial measures, and then the Bangkok rules, which go further in this kind of looking at the needs for women, international human rights law, and so on. But from the international drug control conventions, if you look at them, so in principle, it's really possible to offer, in cases of possession, purchase, or cultivation of controlled drugs for personal use, and other cases of a minor nature, the interventions that we looked at before, such as early identification, treatment, education, aftercare, rehabilitation, and social reintegration, as alternatives to conviction or punishment. And then it's, of course, up to national jurisdictions how they implement that. And this slide I just wanted to share as I'm coming to a closing. So this is kind of based on the United Nations Survey of Crime Trends, and it's from various years and so on. So it's really an estimate, but I think it's kind of an interesting slide. So it kind of shows the estimated number of people in the criminal justice system for drug offenses, and separates between drug possession for personal use and drug trafficking offenses. And according to these estimates, I mean, most people would be in contact for drug-related offenses at the arrest stage. And here the vast majority, 61%, would be for personal use offenses. And at the conviction stage, it goes more closer to 50-50, but 54% at that stage would still be for possession for personal use. And then in these estimates, kind of around the people that are in prison for drug-related offenses, 22%, or in this estimate, close to 500,000 of people would be in prison only for possession for personal use, which, you know, obviously is totally unnecessary, though not knowing, of course, the individual cases here. And in this document that I mentioned on treatment and care for people with drug use disorders in contact with the criminal justice system, one of the things we have done is we have mapped out what kind of legal measures or justice system measures different member states have to divert people from the justice system to the health system, and that has been structured around the different stages of the criminal justice system. So who plays a role at pre-arrest stage? So for example, police, and what are what are alternatives that countries are using? So for example, administrative response with information or referral to treatment. And then similar, this has been done for the other stages. I'm not going into detail for time. We've also asked then member states really what's mostly implemented, and we got a response from 77 countries. There's a little flag missing in Australia. Australia did send us a response, sorry for that. And so, I mean, what came out is that overall alternatives were most used at the trial stage. So that's where 48 countries said that they have diversion mechanisms in place. Less used were kind of pre-arrest mechanisms or post-sentencing options, like early release from prison. And at the pre-trial stage, also a lot of countries, well, at least 43 out of the 77 that responded to us had some options available. So in all of this, kind of all the diversion out, and this is where, again, the linkage with the treatment standards comes in, of course, also makes much more sense if there is an accessible and available and kind of evidence-based treatment services and systems available where people can be diverted to. I mean, that's what we see a lot in low-middle income countries, that the justice system is relatively open to divert people, but there's just no access to treatment in the country. So that, you know, that the infrastructure on the health side is often missing. So, and this is my last slide, I'm closing. So one of the things in this field we were really interested in was to understand better the situation of women in contact with the criminal justice system. And we had an informal scientific network that recently looked both at women using substances and people with drug use disorders in prison. And together with them, and then we asked ENDAC for support, and got in contact with Winifred and Crystal, and they developed a paper which they will now present. But just to say that this paper has also been presented to the Commission on Narcotic Drugs as a conference room paper. So with that, I just want to say thank you, and not only for listening to the presentation, but for everybody who has hosted me during my sabbatical, and all the warm welcome and the open doors. And also, I want to thank really the donors of our programs on treatment of drug use disorders, some of which we have here in the room, some very loyal donors to our work at the prevention, treatment, rehabilitation section. So with that, thank you. And we go over to the next speaker. Thank you so much.
Thank you, Anya. Hi, everybody. So my name is Winifred Asarido, and I'll be co-presenting with Crystal. So today we'll be talking about a review we did in collaboration with UNODC. We sought to look at treatment interventions for women and girls in contact with the criminal justice system. So the review had two main broad aims. One was to look at the factors that influence drug use among women and girls in the criminal justice system. And the second aim was to look at the treatment interventions which were effective for both drug use and drug use disorders. And for that aim, we looked at those who are incarcerated and those who have been recently released from prison. So I'll talk about the first review question. So for review question 1, we searched about 7 databases, PubMed, Medline, EBSCO, and the rest. There was no language restrictions, all studies in low and middle income countries, and studies that focused on women and girls, drug use disorder, drug use, or in contact with the criminal justice system were included. We had over 3,600.
Some of our online viewers might hear, so just adjust the mic.
Hope that's better. We have about 3,600 papers from the search that we did. We exported them to Covidence and screened them. 15 of those studies moved to the final review, and a lot of them were excluded for many reasons, whether it was either in high-income countries or they didn't have risk or protective factors for review question 1. Of all the papers that we included, 7 of them were from Brazil, and all of them were different authors. and the demographics of the participants. Most of them were 30 years and above, followed by those who were 30 years and below. Few studies reported the age ranges for girls who were included in their studies. A lot of the women had low educational achievement, and for those that were employed, they were either in low-paying jobs and they were doing drug trafficking or drug-related crimes to support themselves. The common type of drug that was reported across most of the studies was cannabis. And it was realized that for some of the studies, women were using cannabis to combat PTSD or those who were having some traumatic experiences. And the second type of common drug that was reported was cocaine. And a lot of them also reported drug use whilst in prison. And probably I should also add that some of the studies reported women engaging in drug use for economic survival, and a lot of them were also engaged in family trafficking. So the risk factors identified, most of them were related to either family and relationships, personal factors, or violence. And a lot of papers reported that a lot of the women used drugs because they were experiencing violence, all forms of violence, whether it was sexual or physical violence.
So the second question, we used data from a broader systematic review we started in 2020, and that study was not just focused on low and middle income countries. It was a global review, but for this particular aim, we looked at studies that were in low and middle income countries. And we included studies if the sample focused on women and girls, if they reported drug use or a drug use disorder, and they were either in prison or within 12 months of release. But because of this such a small number that we found a number of studies, we also looked at studies that included women and girls but didn't specifically focus on them. And we only looked at quantitative studies. So this is the broader Prisma diagram for the whole review. So in our main systematic review, we had 131 studies that we analysed, but for the purposes of this question, we only had 3 studies because 55 studies had no women in their sample, and 73 studies did include women, but they weren't in low and middle income countries. And 21 papers out of all those 131 papers, only 21 were actually in all female cohorts, and these were either in the USA or Canada. So I think regardless of the country, women and young girls just seem to be excluded in studies. It's just not, they're just not very well researched. So as I mentioned, we only found 3 studies, 2 were in China and 1 was in Thailand. The studies in China, the interventions were either a peer-based support group or a psychosocial intervention, which was CBT and motivational interviewing and case management. And in Thailand, the intervention was a therapeutic community. None of these studies found any significant differences in drug use between the treatment and the control groups, but the 2 studies that looked at recidivism and criminal activity did find an effect. However, it's important to mention that for the Thailand study, the sample was only 3% female and they were all in the control group. So it's not very informative about what's effective for women and young girls. And for the 2 Chinese studies, 23% was the sample of females in one of them and 22% in the other. So they're very much a minority of the sample. And we also found no evidence of substance use interventions in low and middle income countries, specifically for young girls. So in summary, there's limited studies. As Winifred mentioned, predominant drug use was cannabis before and in prison, and they had a history of incarceration due to drug use. And women incarcerated for drug-related offences was higher, and it was often a coping mechanism for women experiencing violence and traumatic experiences. And sadly, not many studies included women, but that's in general, it's not just singling out low middle income countries. And it's also important to note that it's not just because when you found 3 studies, it doesn't mean those countries don't have programs, it's just there's no available evidence or data that we can work from. So more research evidence is needed. We need to increase evidence-based prevention to reduce drug use disorders and drug-related harms. And it's really important to devise programs that are gender-specific, because there is some research that suggests that the profiles of people who use drugs are different comparing men to women. So it's important to consider gender-responsive treatment programs. So I think we're up to questions now, Michael. Yeah.
Well, thank you very much. That's a very speedy run through 2 years' work, 7 minutes. Very good. Any questions from the floor here? We're going to take questions from the floor, but also we have a range of questions there online too. So we're very keen to pay attention to our 300 listeners online too. So.
None as yet.
No questions.
Not as yet.
Oh yeah, okay. Don, a question from you.
Me?
Yeah.
On spot.
I'm under strict instructions not to ask questions. They need a mic. But I'll make a comment. That problem you're alerting to, the low prevalence of treatment program studies for women, is a big problem across the board. It's the same when you try to look at the factors that get women into prison and the factors that influence their rates of reoffending when they come out of prison. They're all underrepresented. And the argument is always that prison is dominated by men. Well, that may well be true, but there are a lot of women in prison, and the treatment programs they need, in my opinion, are more likely to succeed, because many of them are going to prison for drug problems only, not for robbery, not for burglary and those sorts of things.
That's a very helpful comment. I'll just repeat that so that people online will have heard it. Don Weatherburn was making the comment that the factors in this study around drug use apply probably across the prison system in general for women, and I think the big take-home message is the needs of women in the criminal justice system are significantly neglected, and there's a need for improvement. So that's not just in research, but in actual action. No questions?
Well, related to that point, sorry, Michael, you can say. So one of our attendees online has asked what type of treatment programs would our panellists recommend for women when they're in prison, when they're likely to be in custody for less time than men, generally speaking?
Crystal? Maybe Anya?
Yeah, I mean, I think, is this working? Yeah? Can we hear, we heard online on this? Or in the room? In the room we are missing. Okay, online we are, I will just shout to the room and hope online you can hear us. Well, I mean, there's limited evidence, right? So, I mean, Crystal was talking about different psychosocial programs, but I think in general, best evidence for treatment in prisons is around, for people with opioid use disorders, around pharmacological treatment for opioid dependence. So that would not be different for women. And then, you know, a lot of the other kind of general recommendations around doing screening very early on, at least identifying if people are in withdrawal and have any needs, kind of address those immediately and early on, not wait too long. And I mean, and I think that there's a lot of discussion that this kind of criminal justice contact, especially if it's a short-term contact, like in the question asked, you know, might be a good opportunity then to at least offer linkages to services, maybe in some cases already to start some kind of treatment interventions that then can be continued in the community. I mean, it really depends also so much on the setting and what's available in the community. And I mean, you guys have been looking at low middle income countries, right? So in there, the chances, you know, that services in the community are available are immediately much less. So, yeah.
I think the other point that's worth being mindful of is that most of the women, the age range tends to be of childbearing age, and there's all sorts of issues around women being either separated from their children or also being pregnant. And actually women in prison are often placed in prisons at great distance from their home. And also in most settings, about 90% plus of visitors to prisons are women, and men tend to not visit prisons very much. So there's a very complex issues of networks, of social responsibilities that people are ripped out of, and very hard to bring them back into.
Yeah, and you know, maybe just to add again, I had that on my slide, but I mean that was likely also one of the reasons when the Bangkok rules were developed to kind of pay special attention to the needs of women and even more emphasize these aspects of having alternatives to incarceration in place and keeping women in the community when they're in contact with the criminal justice system, be it for drug-related offenses, but the Bangkok rules are broader, right? They're not only for drug-related offenses, but in general.
And we've got another question here with the study around women. Was juvenile detention included? And if so, what sorts of information and data did you find in that space?
Yes, in our systematic review it was. It's just that in terms of low middle income countries there was nothing, so, but juveniles were included. But I think, I don't know the exact numbers, but in the broad systematic review, I think even juveniles, there wasn't a lot of papers, but I don't know the exact number.
We've got nothing else online. Are there other questions in the audience?
Tom Santo up there.
Thank you. Anya, I had a quick question about the quality ratings and assurance and how that was done within countries, and if you went to multiple sites, because I know, for example, in Australia, the drug treatment availability in cities is far different than it is in rural areas. And when you're grading a large country's drug treatment quality overall, did you just look at one city or one place, or how did that work?
Yeah, so that was different in different countries, and it had a lot to do with what was feasible, also the resources available and so on. So I mean, I'm just thinking, so for example, we did in Pakistan, kind of there we worked on the systems standards, and there were consultations with different groups that included policymakers, service providers, and so on in all the provinces. And what helped there, that part of this was done online, right? So that was during the pandemic. And then afterwards, I mean, what I think is actually interesting, and in that sense, I also would not take the quality assurance tools maybe as too scientific, but as I really said, as living documents, what they're really, really good at is to open a discussion and have these processes of self-reflection, right? To say, this is what our pyramid looks like. Maybe, we want to think about it again. So, I mean, the example from Nigeria, there was only in one state, and we are now having the opportunity to work in a second state. So there it goes more consecutive. In Pakistan, consultation was kind of countrywide. But in both cases, the outcome was that national standards, national guidelines need to be developed. And in both, so the entrance door was different, but I think, it led maybe to similar discussions or similar identifications of needs.
So I'll ask a question of Anya. How much would you think, how important would it be for these guidelines to be contextualized in the context of the country's broader health guidelines?
So the international standards and broader health guidelines. Pros and cons, I think, in the real world, right? Sorry, I thought it doesn't work, so I didn't use it. So I would say pros and cons, right? So obviously, we're always asking for mainstreaming of drug treatment, so to say, in general health. And that's what, WHO, for example, also developed the MHGAP program for, where substance use is one, so to say, of different interventions for primary health care. I think what we see in reality is that often substance use treatment, and within that drug treatment, is so much neglected and forgotten that sometimes in the real world, it's helpful kind of to have an extra boost and at least initially maybe have also something that's standalone and can get kind of some additional attention. And then as health systems developed, because again, that's the other challenge, right? That in a lot of countries where we are working or where you kind of looked at the data, the health systems are also at such a bare minimum in terms of offering services that an integration, in a country where there's one psychiatrist or so, an integration would be very much a challenge. So, I mean, no conclusive answer. I think the vision would be the, integration, mainstreaming in healthcare, but maybe not overnight. I mean, just for some drug treatment to take place, it often needs initially kind of a special place in health systems.
Yeah, no, the reason I ask is because I've been in a few countries doing some assessment type things where it's obvious there's been no health care provision whatsoever, and at that point in time it feels difficult to be pushing for a drug and alcohol treatment system when actually people have access to nothing.
Yeah, and maybe to say that around treatment in prison we have similar challenges, right? Because there is this principle that the treatment in prison should be at least of the same quality like treatment in the community. Only when there's hardly any quality treatment or any accessible treatment in the community, then it's often a challenge, and we are very hesitant to start working on treatment programs in prison, so that prison does not suddenly become the only place where you have access to any drug treatment, right? So I mean, often the programs really need to strengthening health services and then drug treatment services. One of the other reasons why really we try to do a lot of our treatment programming together with the World Health Organization, who then has a wider mandate around the health system.
Thanks, Anya. Yeah.
Maybe you'd like to read this, Michael, because I don't have a mic.
Okay, the next question is, are Crystal and Winifred planning on doing further research and recommendation program evaluations in the same space? Curious and keen to see more come out about women in custody and support and treatment on exit.
Yes, I'll comment on that. So we do have plans of expanding the review beyond low and middle income countries to look at substance use among women and girls globally, and also to look at the negative health, social and economic consequences regarding substance use. So we do have plans on expanding. Yeah.
Okay, that's great. Rhea?
Hi, thank you so much for your presentation. You were commenting, I think in response to Tom's question about how you're sort of working with policymakers and service providers when you're doing the quality assurance. I was wondering whether you could comment on whether the involvement of service users and, maybe when throughout those sort of processes that there may have been involvement.
Have people heard that question? The question is about the potential involvement of service users or, yep.
Yeah, so I mean, the quality assurance toolkits, the way they are implemented, especially kind of at the service level, there is always a component of kind of interacting with the service users, and a lot of those kind of, which was there around patient-centered care, involves kind of that the information needs to come from the actual service users and so on. How that gets implemented is sometimes, different and so from one place to the other. But the idea is that, yes, that's very much kind of part of the quality assurance work. So, I mean, idea is to make the voice heard. Does it always happen? I can't guarantee.
Okay, well, look, I think you've been a very well-behaved audience, I have to say. You've listened attentively. You've asked interesting questions. And I'd particularly like to thank our three speakers for not just the speaking, but the great work behind the speaking. And I'd also like to thank Anya for her attention and time when she's been here in Australia. She's been very enthusiastic about getting around. She's networked very well and
Learned a lot.
well, hopefully learned something, but she knows so much. I'm sure she didn't learn that much. But good luck with everything. And I'd like to thank all of the people online. As they say, if you have been listening, thank you for listening. Okay. And goodbye. And the next meeting, the next session, Julian, will be
Yep. If you click the next slide, Michael, it'll pop up. Keep going.
Okay, so the next webinar will be on the 20th of April, and it's drug use at music festivals, key findings and harm reduction recommendations. And the one the following week on the 27th of April will be current trends in overdose and other drug-induced deaths in Australia with Associate Professor Amy Peacock. So again, thanks everybody, and come again.